Welcome to this next section, a very important section on senior health products, and we start out with Medicare. Medicare is one of the most significant government programs ever implemented and helps millions of people nationwide. Medicare is one of the four parts of the federal Social Security program. Medicare is a federal health insurance program for those 65 and older, persons of any age with permanent kidney renal failure, and certain disabled persons. The Center for Medicare and Medicaid, known as Medi-Cal in California, administers the program. The Social Security Administration offices take the applications for Medicare and provide general information about the program. Medicare provides coverage for hospital care, Part A, medical services from doctors, Part B, and prescription drugs, Part D. Medicare Part C, also known as Medicare Advantage, offers beneficiaries the option of receiving their Medicare benefits through private health insurance plans. Part A is financed by the Social Security payroll tax, FICA, deductions, which are paid both by the employee and matched by the employer. Participation is mandatory for all employees and employers and the self-employed, with very few exceptions. Medicare beneficiaries, those whose medical bills are being paid by Medicare, also participate in the financing of Part A by paying deductibles, coinsurance, and premiums if they do not qualify to receive Part A premium for free. The majority of Medicare beneficiaries receive Part A premium free at age 65. Medicare consists of several program components or parts, each of which provides different benefits and services. Here's the brief summary. There's a chart in your text that shows the type of benefits listed for Part A, Part B, Part C, and Part D. So Part A is mandatory, and that provides hospital insurance, including skilled nursing, some home health care, and hospice services. Part B is voluntary. It pays for the physicians and outpatient service fees, some home health care, durable medical equipment, and ambulance services, but you have to pay extra to buy Part B. Part C is an alternative to receiving traditional Medicare. Beneficiaries enroll in a Medicare Advantage plan, and you can get the Medicare services delivered through your own health insurance company. And then Part D is also voluntary. It's the prescription drug benefit. You have to pay extra for that. Let's talk about the original Medicare and Medicare Advantage plans. In 1965, the Social Security Act established both Medicare and Medicaid Medicare, and it was the responsibility of the Social Security Administration, while federal assistance to the state Medicaid program was administered by the Social and Rehabilitation Service. Medicare is our federal health insurance program and serves 41 million people, with 35 million of those people being age 65 or older, and 6 million are under 65 and have permanent disabilities. Medicare has two main choices for delivery. There is the original Medicare, which is a fee-for-service plan consisting of Part A and Part B, and then the Medicare Advantage plan, which is managed care, much like an HMO or PPO, that includes the benefits provided by both Part A and Part B. With original Medicare, Part A and Part B, the beneficiary is not limited to any service area or any network of providers. They can receive services from any doctor or hospital that accepts Medicare in any state. In most states, Medicare beneficiaries do not need a referral to see a specialist. However, the specialist must be enrolled in the Medicare program. Also, with few exceptions, most prescriptions are not covered in original Medicare. You have to buy Part D to get the prescription drug coverage. The Medicare beneficiary, the patient, has a deductible for both Part A and Part B. Both Part A and Part B have out-of-pocket expenses such as co-payments or coinsurance for hospital stays, coinsurance for medical services, and costs of the first 3 pints of blood that the Medicare beneficiary must pay for under both Part A and Part B. The amounts that the Medicare beneficiary must pay out of pocket are established by Congress and change yearly. If the Medicare beneficiary wanted coverage to pay the expense not covered by Medicare, they would purchase a supplemental insurance plan from an insurance company to fill in the gaps in their original Medicare coverage. These plans are called Medicare supplements or Medigap insurance. Though the policies are standardized, the costs vary based on the plan chosen and the insurance company. These were originally set up as 10 Medicare supplement policies known as Plans A through J. Prescription drugs were covered by only 3 of them of the 10 supplemental policies, Plans H, I, and J. Today the 10 plans are A, B, C, D, then Plan F, then Plans G, K, L, M, and N. Prescription drug coverage is provided under Coverage D and must be purchased and paid for extra. So let's talk about who's eligible. If an individual is approaching age 65 and already receiving Social Security or railroad retirement benefits through early retirement, they'll automatically be enrolled in Medicare Parts A, hospital insurance, and Part B, medical insurance, when they turn 65. Approximately 3 months prior to their 61st birthday, Medicare will send them an initial enrollment package containing general information about Medicare, a questionnaire, and the red, white, and blue Medicare card. If an individual is approaching age 65 and not receiving early retirement Social Security or railroad retirement benefits, they can apply for Medicare during the 7-month initial enrollment period, IEP. The IEP begins 3 months before they turn 65 and includes the month of their birthday and ends 3 months later. If they enroll 3 months prior to turning 65 or the month they turn 65, they're covered on the first of the month when they turn 65. If the initial enrollment is missed, and the individual will be subject to a late enrollment penalty, 10% of the applicable premium for twice the length of time the beneficiary was not enrolled in Part A, and 10% lifetime penalty for each 12-month period not enrolled in Part B. So you must enroll when you're eligible, or you will get penalized with paying higher premiums. Those 65 years old and older are not eligible for Social Security benefits free because they are not fully insured, may purchase Part A and Part B for a premium. So if you're not fully insured for Medicare, you haven't worked at least the 10 years and qualified with enough credits, you can still buy Part A and Part B, but you have to pay for it. Those who are 65 and did not enroll in Part A when they were first eligible, their monthly premium will go up 10% due to the penalty. The higher premium will be required for twice the number of years that the person could have been enrolled but did not sign up. This is the government's way of forcing people to make sure they enroll in Medicare so that the law of large numbers works and they can accurately predict what the health care costs are going to be in the future. To be eligible to enroll in Medicare, an individual must be a citizen of the United States or have been a legal resident for at least 5 years and be 65 or older and have worked or their spouse has worked for at least 10 years, earning 40 quarter credits, which makes you fully insured in the Medicare covered employment. Fully insured people receive Part A premium for free. So you have to work 10 years and get 40 quarter credits. If you're age 65 or older who does not qualify for Part A premium for free, you can purchase it for a monthly cost. Persons who are younger than 65 with a disability and have received Social Security disability insurance or railroad retirement disability payments qualify for Part A premium for free. And those who qualify due to kidney failure, known as end-stage renal disease, ESRD, receive Part A premium for free. Those who have Lou Gehrig's disease and have received their first payment for Social Security disability payments also qualify for Medicare for free. Persons who are 62 and collecting early retirement are not entitled to Medicare until age 65. That's important to note. Just because you're getting Social Security early doesn't mean you can get Medicare early. You can't. You only get Medicare once you turn 65. Let's talk about the Social Security disability income. For those younger than 65 and receiving disability benefits under Social Security or railroad retirement, they're automatically enrolled in Medicare Part A and B on the 25th month of their disability payments. So if you're not NCARE renal disease, or Lou Gehrig's disease, so if you don't have those, but you're disabled from something else, maybe an accident or maybe you had a stroke, and you're getting Social Security because you had the stroke, after you've had Social Security for 24 months, in the 25th month, you then are automatically enrolled in Medicare. If you want both Part A, hospital, and Part B, medical insurance, you simply sign your Medicare card and keep it in your wallet. They still need to sign up separately, though, for Part D, prescription drugs. Let's now talk about the end-stage renal disease and amyotrophic lateral sclerosis, ALS, known as Lou Gehrig's disease. Medicare coverage for the disabled and people with kidney failure began in 1973. End-stage kidney disease is a complete or near complete failure of the kidney function to excrete waste, concentrate urine, and regulate your electrolytes. People diagnosed with either end-stage renal failure or Lou Gehrig's disease do not have to be 65 to qualify for Medicare, and they don't have to wait 25 months to be eligible, as in the case with a regular disability-triggered Medicare. ERSD, you're eligible for Medicare on the first day of your 4th month of dialysis, or immediately if you do home dialysis, or when you're hospitalized for kidney transplant. ALS, Lou Gehrig's disease, you're eligible as soon as your Social Security disability income payments begin. Let's now talk about in detail the Part A hospital coverage. Before we discuss the coverage provided under Part A, we need to discuss the effect of the ACA, Obamacare, on the Medicare program. If consumers are enrolled in Medicare, they do not need to do anything with Covered California because they're already covered. Also, Covered California does not sell Medicare Advantage plans, such as Medicare HMOs and PPOs and Medicare Part D prescription drugs. So you can't buy supplemental Medicare plans through Obamacare. Generally, someone who's eligible for Medicare, even if they do not enroll in it, cannot receive tax credits to help them pay for Covered California health plans. Additionally, if a consumer chooses to enroll in Medicare later, they may have to pay the late enrollment penalty. So there's really no overlap. If you're on Medicare, you can't get Obamacare. And if you're supposed to be on Medicare and don't sign up, you still can't get Obamacare. Let's now talk about the inpatient coverages. The hospital coverages under Part A include inpatient services, including semi-private room and board, nursing services, and medically necessary care. It includes post-hospital skilled nursing. If the patient is required, the patient first must be required to be hospitalized for 3 days, and then they can enter an accredited care facility within 30 days of being discharged from the hospital. Care must be a type that can be performed only by or under the supervision of a licensed nursing personnel, and the conditions must be restorative, meaning you're going to get better. In other words, if you had cancer surgery and your cancer is still there, you're not going to be able to go into a skilled nursing center. It's like somebody who breaks their hip and they've had surgery and now they need skilled nursing care. Then Medicare will pay for that for up to 30 days because your hip will heal and you'll get better and be able to walk again. If you're permanently sick, you can't get this skilled nursing care paid for by Medicare. So Medicare and Medicare supplements provide very limited nursing home benefits, and Medicare does not provide long-term care. If you need to go into a nursing home permanently, you can't get Medicare coverage to pay for that. Let's now talk about home health care post-hospital. This benefit provides that the Medicare beneficiary first be hospitalized and then services are provided by a home health agency that comes into your home. The agency provides skilled nursing or therapeutic services in the home. It covers services for the part-time, intermittent skilled care, home health aides, durable medical equipment, medical supplies, and other services. So you can get home health care paid for by Medicare. You just can't get long-term care from a nursing home paid for by Medicare. So the in-home health care is a lot cheaper, and Medicare will pay for that. It's called home health care under Part A of Medicare. Then hospice. This pays all pain relief, symptom management, and support services for the terminally ill. Covers expenses not normally covered by Medicare, and the patient has a small cost for outpatient drugs and respite care. This is usually provided in the home and is a very valuable service to people who are diagnosed as terminal and usually are going to die within 6 months. Then psychiatric care. Inpatient psychiatric care is provided for 190 days, lifetime. So you get 6 months plus 10 days of psychiatric care paid for by Medicare. And then blood. When furnished by a hospital or skilled nursing facility during a covered stay, but it does not cover the cost of the first 3 pints of blood. All blood after 3 pints is paid for by Medicare. And what's excluded from this are physician and surgeon charges, pathologist, radiologist, anesthesiologist, private duty nursing, personal conveniences, supplies, and equipment used outside the hospital. None of that's covered under Part A. Part A hospital covers hospital, hospice, home health, and skilled nursing facility in your home, but not in a permanent nursing facility. So now let's talk about the benefit period. Part A pays per the benefit period. A benefit period begins on the first day of hospitalization and ends when the patient has remained out of the hospital for 60 consecutive days. If the patient is readmitted within 60 days, future hospital days are added to the original hospitalization. If the patient is readmitted after 60 consecutive days have passed, this is considered a new benefit period. Why is that important? Because there's a limit to how much Medicare will pay per hospital period. The first 60 days, the patient is only responsible for paying the deductible. Once the days accumulate beyond 60 days, the patients begin to pay a daily amount out of their pocket. These are referred to as coinsurance days, and sometimes the test refers to these as copay days. Let's now talk about the deductibles. At the beginning of every new benefit period, the Medicare beneficiary is required to pay a deductible. Once the Medicare beneficiary has paid the amount in covered medical expenses, then Medicare pays the rest for the first 60 days of a benefit period, 100%. So once you meet your deductible for that benefit period, everything is covered up to 60 days, and that deductible in 2020 was $1,408. So if you go in for heart surgery and the medical bill is $80,000, you pay $1,408, and then Medicare pays all of the rest. Let's talk about copayments. After accumulating 60 days during the benefit period, the Medicare beneficiary must pay a set amount per day. So if your hospitalization goes past 60 days, you're going to pay some out of your pocket per day. The 61 to 90 days, which is the next 30 days after the 60 days of accumulated hospitalized days, the Medicare beneficiary must pay a per day charge out of pocket. Should the Medicare beneficiary need to use any of their lifetime reserve days, the daily charges they are responsible for is even higher. After the 60 lifetime reserve days are used up, after 90 days, Medicare pays nothing, and the Medicare beneficiary is responsible for 100% of the charges. There's no maximum out-of-pocket expenses under Medicare Part A and Part B. So to understand that, you pay your deductible at the beginning of the benefit period. Medicare is going to pay everything up to 60 days. After 60 days, from 61 to 90, you're then going to pay part of the cost on a per day basis. You have some reserve days that you can transfer to use, but once those reserve days are used up, you're out. Medicare won't pay anything else. So if you're hospitalized for 6 months, for example, Medicare isn't going to pay all of that. So it's important that you understand that Medicare covers everything for 60 days, part of it for 61 to 90, and then everything once you use your reserve days. Once the reserve days are done, you have no more coverage. So Medicare is not open-ended, 100% coverage forever. You need to know that. Let's now talk about home care and hospice care. Home care under Part A requires that the patient first be in the hospital. However, hospice care does not. It is for terminally ill patients. The hospice benefit allows the patient and family to stay together in the comfort of their home in most situations. It requires a doctor to certify that the patient has a life expectancy of 6 months or less. Let's now talk about the mental health inpatient hospitalization lifetime limit. Mental health benefits and lifetime limits are the same as inpatient beneficiary per day, copay, coinsurance days, and deductibles. However, there's a cap of 190 total days for this type of hospitalization. There's a chart in your text that shows the different levels of care and how much Medicare will pay for it, what the insured deductible is, and how much per day the customer has to pay for. For example, inpatient hospital care. On the first 60 days, all of it's paid by Medicare except your initial deductible, and the deductible is $1,408. The days 61 to 90, Medicare pays for everything except for $352 a day. So if you use all 30 days in that 61 to 90 period, you're going to owe $10,000. You pay $352 a day. And then after that, from 91 to 150 days, you can get to use your lifetime reserve days, and Medicare will pay everything except $704 per day. After 150 days, Medicare pays nothing, and $704 a day is about $20,000 a month. So study that chart and look at the different coverage levels and see the time limits. Let's now talk about Part B, medical insurance. Part B is known as medical insurance, and sometimes the test refers to it as supplemental medical insurance. The Part B program is voluntary, meaning it's optional, and it's designed to supplement Part A by paying medical services not covered by Part A, such as outpatient services and doctor's fees. The only qualification for being able to enroll in Part B is that the Medicare beneficiary is eligible for Part A. Just like with Part A, the individual must be a citizen or a legal resident for 5 years. Everyone pays a monthly premium for Part B, even if they're receiving Part A for free. So you got to remember, Part A is the only part of Medicare that's free. Everything else, there is a premium due, paid for by the insured. Let's talk about enrollment in Part B. Most individuals who file an application for Social Security or railroad benefits during the initial enrollment period, 3 months before their 65th birthday or 3 months after, enroll in Part B unless they refuse Part B in writing. Individuals who do not enroll when first eligible in their initial enrollment period can enroll during a general enrollment period in January through March of the following year. Their Part B coverage would then begin on July of the year in which they enroll. The only requirement for eligibility for Part B is that you are eligible for Part A. And if you don't want Part B, you have to reject it in writing. If you do not take Part B when you enroll in Part A, every 12 months you wait, there's a 10% increase in the premium you'll pay for the Part B as a penalty. Now there can be some special enrollment periods which allow beneficiaries to make enrollment changes outside of the general enrollment period. A number of special enrollment periods exist for Medicare Advantage and for disenrolling. For example, someone who moves out of a Medicare Advantage plan or service area has a special enrollment period to enroll in a plan that serves their new service area. Beneficiaries who move into, reside in, or move out of a nursing home may also have a special enrollment period, and individuals who are eligible for Medicare and Medicaid have a special enrollment period that allows them to change Part D drug plans at any time. Let's talk about the special enrollment period in more detail. Medicare beneficiaries who did not enroll in Medicare at all when they first became eligible, or who did not accept Part B when they enrolled in a Plan A, originally can enroll during the general enrollment period. The GEP extends from January 1 to March 31 each year, and coverage will not begin until July 1. Let's talk about the monthly premium. Part B is an optional coverage, and everyone must pay a premium for Part B. The current premium is $104.90 per month. Higher income beneficiaries will pay higher Part B premiums. The government finds out from your tax return what your income is, and if you're over the threshold, you could pay as much as $150 a month for your Part B coverage. Premiums for Part B will be deducted from the person's Social Security, railroad retirement, or federal civil service retirement benefits. So they come out of your Social Security payment automatically. Let's talk about your annual deductible and coinsurance. Part B is based on a calendar year and not on a benefit period. This means that the Part B coverage runs from January 1 to December 31 of each year. Part B has an annual yearly deductible and an 80-20 coinsurance requirement. Some services require a copay instead of the 20% coinsurance charge of the approved amount. However, there is no maximum out-of-pocket limit for Part B. If the approved amount was on your medical bill was $100,000, then Medicare would pay $80,000 and the patient would pay their 20% or $20,000. Medicare Part B covers medically necessary services and supplies needed for the diagnosis or treatment of your health condition. This includes outpatient services received at a hospital, doctor's offices, clinics, or other health facility services. Medicare Part B also covers many preventative services to prevent illness or deter them at an early stage. Together, Medicare Part A and Part B are known as the original Medicare plan. So original Medicare is Part A and Part B. Part B provides three categories of covered services. Medically necessary services, services or supplies that are needed to diagnose and treat your medical condition and that meet accepted standards of medical practice. So it covers the medical expenses, it covers clinical laboratory services, it covers home health care services, outpatient hospital treatment, mental health services, and blood after your first 3 pints. Physicians and surgeons services are covered, so doctors, surgeons, osteopaths, and others. Services and supplies furnished as part of these services, whether performed in the hospital, the doctor's office, or at a clinic. It includes services of the doctor's office's nurses. Then preventative services are covered. Healthcare to prevent illness or detect it at an early age when treatment is most likely to work best. For example, pap smear tests, flu shots, and colorectal cancer screenings are all paid for by Part B. The patient pays their copayment or coinsurance amount for these services. Part B home health hospice, home health care, or hospice out-of-pocket expenses. Both Part A and Part B cover home health and blood after the first 3 pints. The difference is that the home health, hospice, or blood paid under Part B do not require prior hospitalization. It covers this type of care that's not covered under Part A as inpatient care. Medicare and group insurance. The Tax Equality and Fiscal Responsibility Act, TEFRA, amended Social Security to make Medicare coverage secondary to the group plans of 20 or more individuals. It's also amended the Age Discrimination in Employment Act to require employers to offer the same coverage to older employees as they do to younger employees, and to keep group term plans from discriminating in favor of key employees. Payment differences for using approved physicians versus non-approved physicians. Medicare assignment means that your doctor, provider, or supplier has signed an agreement with Medicare to accept the Medicare-approved amount as full payment for covered services. Some providers, called participating providers, have agreed to submit all their Medicare claims on an assigned basis. However, there are non-participating providers, and they may choose whether or not to accept assignment on each individual claim. The most important advantage of assignment is that the provider who accepts Medicare agrees to accept Medicare's approved amount as full payment for the covered services. So Medicare doesn't limit you what doctors you go to. You just need to make sure that the doctor you go to is an assigned doctor. He will accept the Medicare fees. If he doesn't, you could pay a lot more out of your pocket. The doctor, provider, or supplier is supposed to submit the claim to Medicare for any Medicare-covered services they provide and are not allowed to charge Medicare beneficiary for doing so, again, if they're enrolled in the Medicare assignment program. Participating physicians are listed in the Medicare participating directory and have accepted the Medicare assignment, which means that the physician will charge the fee schedule and nothing more. If a patient decides to go outside the directory to a non-participating physician, then the patient will be responsible for the Medicare fee schedule minus 5%. So you don't want to go outside the participating physicians that are on the list. The Center for Medicare and Medicaid Services, previously known as the Healthcare Financing Administration, is a federal agency within the United States Department of Health and Human Services that administers the Medicare program and works in partnership with state governments to administer Medicaid, the state children's health insurance program, and health insurance portability standards. So know that Medicaid is a state program. Medicare is the federal program. Many states get money from the federal government to run their Medicaid program. So the state of California runs Medicaid, federal government runs Medicare. Medicare supplement plans, also known as Medigap plans, have been standardized by the Center for Medicine and Medical Services, currently into 10 different plans, labeled A through N, and they're sold and administered by private insurance companies. Each Medicare supplement or Medigap plan offers a different combination of benefits. Since Medicare supplement is private insurance and not government-sponsored, the rules governing the sale and offering of a Medigap insurance policy can vary state by state. Every Medicare supplement policy must follow federal and state laws designed to protect the consumer, and the policy must be clearly identified as Medicare supplement insurance. Insurance companies in most states can only sell you a standardized Medicare supplement policy identified by letters A through N. Each standardized Medicare supplement policy must offer the same basic benefits regardless which insurance company sells the plan. Cost is usually the only difference between Medicare policies with the same letter sold by different insurance companies. So this was to standardize the medical products so people could easily compare what they're getting and what the costs are, the apples to apples comparison. So you can get a quote from Medicare Plan F from 3 or 4 different insurance companies and see which one has the best price. And the coverages are exactly the same. Medicare supplement policies are neither sold nor services by the state or federal government, and no agent or company may make statements that they represent the Medicare program or any governmental agency. They are sold and services only by private insurance companies. So there's a chart in your book that shows all the different coverage levels for plans A through N, and you should study that to see the different levels of coverage. The best plan is Plan F. It's also the most expensive because Plan F includes all the deductibles covered and the drug Plan B and Plan D all covered. So look at the different charts there and see and get the idea of how they are better and better with more and more coverage and fewer deductibles the higher the letter that you purchase in the Medigap plans. Starting January 1, 2020, Medigap plans sold to new people with Medicare won't be allowed to cover the Part B deductible. Because of this, plans C and F will no longer be available to people new to Medicare starting January 1, 2020. If you already have either of these two plans or the higher deductible version of Plan F, you're covered by one of these before January 2020, you'll be able to keep your plan. If you were eligible for Medicare before January 2020 but not yet enrolled, you're not able to buy these plans. So as of January 2020, you can no longer buy a plan that waives the deductible in Part B. Generally, Medicare supplement policies don't cover long-term care, like care in a nursing home, vision or dental care, hearing aids, eyeglasses, or private duty nursing. Types of coverage that are not covered by Medicare supplement policies are the Medicare Advantage Plan, Part C. You have to buy that one separately as Part C. Medicare Prescription Drug Plans, Part D. You have to buy that separately as the Part D coverage. It doesn't cover anything covered by Medicaid. It doesn't cover things that are covered by your employer or union plans, including the Federal Employee Health Benefit Program if you work for the federal government. It doesn't cover TRICARE. It doesn't cover veterans benefits. It doesn't cover long-term care insurance policies or long-term care costs. Indian Health Services, tribal and urban Indian health plans are not covered as part of a Medigap policy, and qualified health plans sold in the health insurance marketplace, meaning Obamacare, are also not part of a Medigap policy. Medicare's select plans are Medicare supplemental health insurance products. They are almost identical to standard Medicare supplemental insurance policies, also known as Medigap. They are a combination of the standardized Medicare supplement plan, Medigap, and a PPO. A few companies in California sell Medicare Select plans. Let's now review the California code requirements for Medicare supplement policies. Besides standardizing Medicare supplements and Medicare Select plans, the California Insurance Code also requires the following. Insurance companies were not required to sell all 10 original Medicare supplement plans. However, an insurance company must offer Plan A, the core benefits, if they offer any Medicare supplement policy. If they offer any other Medicare supplement policies, they must also offer either Medicare Supplement Plan C or Plan F. And the following benefits are required in each of the standardized plans. Any Medicare supplement policies advertised, sold, or issued in California must meet all of the following minimum standards. Pre-existing conditions cannot be more restrictively defined. Sickness and accidents must be covered the same. Medicare supplements must provide benefits that coincide with changes in Medicare deductibles and coinsurance. Spousal coverage cannot be terminated if the insured is terminated, except for non-payment. Must be issued guaranteed, renewable, and non-cancelable, and the insurance company shall not cancel or non-renew the policy solely on the basis of the health status of the individual. And an insurer may not cancel or non-renew a Medicare supplement for any reason other than non-payment of premium or material misrepresentation. And the contestability period for Medicare supplement insurance is 2 years. If a group Medicare supplement policyholder replaces its policy with another, the succeeding insurance company must offer coverage to all persons covered under the old group policy on its termination date. And if a policy has begun to pay benefits to an insured and is subsequently terminated, those benefits cease. However, the benefits may be conditioned upon the continuous total disability of the insured, limited to the duration of the policy benefit period, if any, or payment of maximum benefits. In other words, if you're already on claim and you terminate your benefits, those claim benefits will continue. A supplement policy may be suspended for up to 24 months if the policyholder is entitled to Medi-Cal, but only if the policyholder notifies the insurance company within 90 days of entitlement. And a policy cannot limit coverage exclusively to a single disease or affliction. And every insurer must make available a policy that includes only the basic core benefits to every prospective insured. An issuer may make available any of the other Medicare supplement benefit plans in addition to the basic core plan, but not in lieu of the basic core plan. All plans include the core benefits. The additional benefits are shown in the charts above. Plan A is a core package of benefits. Coverage for Plan A has daily co-payments for eligible expenses from the 61st day to the 90th day in a Medicare benefit period, and coverage of Plan A Medicare daily co-payments required for eligible expenses incurred during the use of Medicare's lifetime hospital inpatient reserve days, and upon exhaustion of all Medicare hospital inpatient coverage, including the lifetime reserve days, coverage of all Medicare Part A eligible expenses subject to a lifetime maximum benefit of an additional 365 days. In other words, your Medicare supplement plan can produce additional coverage up to 365 days. Coverage under Medicare Part A and Part B for reasonable cost of the first 3 pints of blood. In other words, the regular Medicare plan makes you pay for the first 3 pints of blood. The Medicare supplement plan will cover those costs for the first 3 pints of blood. And coverage for coinsurance amounts for Medicare Part B eligible expenses, regardless of hospital confinement, subject to the Medicare Part B deductible. In other words, your supplement plan can cover the Medicare Part B deductible that is normally not covered. All Medicare Select policies must meet these CIC, California Insurance Code, requirements, and the commissioner must approve of the issuer insurance company's plan of operation, and the network providers can provide the services with reasonable promptness with respect to geographic location, hours of operation, and are available within usual travel distances. In other words, the Department of Insurance has the right to review your plan and can you deliver the services in a timely manner to your customers. Additional code requirements. Insurance companies are not required to offer all the plans, but the insurer must offer the Plan A core benefits available to every prospective insured if they offer any other plan. If the insured is 65 or older and purchases a supplemental plan within 6 months of enrolling in Plan B, they cannot be rejected or rated by the insurer of their choice. If they wait more than 6 months before enrolling, then they can be rated or rejected. So it's the customer's best interest to enroll in these supplemental plans within 6 months. The guaranteed issue rights are rights you have in certain situations when insurance companies are required by law to offer you certain Medicare supplement Medigap policies, even if you have health problems, and must cover any pre-existing conditions and then cannot rate or charge you more. You have this right when your Medicare Advantage plan stops service in your area, your group health plan is ending, you move out of the Medicare Select policy's service area, you are within your trial period and want out of the managed care plan, or the insurance company goes bankrupt and you lose your coverage. With respect to guaranteed issue of a Medicare supplement policy, application forms shall include the questions designed to elicit information as to whether or not another health policy in force is intended to be replaced. A supplemental application or other forms has to be signed by the applicant and agent and can contain the questions and statements to be used. In other words, you have to admit if you're going to use this new plan to replace another existing plan, and then replacement rules apply. We'll get to that in a minute. The California Insurance Code also lists what the commissions can be. So first-year commissions or other first-year compensation cannot be more than 200% of the commission paid for selling or servicing the policy in the second year. Renewals must be the same as provided in the second year or the second period and must not be paid for fewer than 5 years. An insurance company shall do all the following in regards to inappropriate sales activities and replacement. In other words, the code requires insurance companies to police their agents and make sure they're not participating in inappropriate sales activities or inappropriate replacement activities. So the insurance company has to establish protocols that offer fair and accurate comparisons. They must establish procedures to ensure that excess insurance is not sold or issued. They must promptly display on the first page of the policy and the outline of coverage the following: notice to buyer, this policy may not cover all your medical costs. They must make reasonable effort to establish whether or not the applicant already has health insurance and the types and amounts of that insurance. They must establish auditable procedures for verifying compliance with this law. There's no twisting, high-pressure tactics, or cold lead advertising allowed. The terms Medicare Supplement, Medigap, Medicare Wraparound, and words similar are not used unless the policy issued is in full compliance, and they must make sure the purchaser of a copy or they must make sure that the purchase of a policy or replacement is appropriate. So there's very strict guidelines covering what agents can and cannot do in selling Medicare and Medigap coverage. Application forms shall include questions to elicit information as to whether the proposed insured currently has a Medicare Supplement or Medicare Advantage and whether this, when you're selling them, is designed to replace the one they already have. In addition, there's Medicare disclosure requirements. Disclosure requirements include an outline of coverage that must be given to all applicants at the time of the application, and it must contain the following disclosure statements. This policy may not fully cover all your medical costs. Neither this company nor any of its agents are connected with Medicare. This outline of coverage does not give all the details of Medicare coverage. Contact your local Social Security office and consult the Medicare handbook for more details. In other words, they refer people to the material to look up the actual details. The outline summary is not complete. As we discussed above, the application must include questions to elicit information as to what coverage the proposed insured already has and whether or not they're going to replace that coverage with this one. In which case, replacement rules apply. And let's review those. We talked about those in prior chapters with life insurance. Should the policy the proposed insured is purchasing, then a notice of replacement form must be presented, signed by both the agent and the proposed insured, and a copy given to the proposed insured. So if they answer yes, that they are replacing another policy, this notice of replacement form has to be filled out. The replacement notice must be printed no less than 12-point type and basically the same as the notice of replacement form developed by the National Association of Insurance Commissioners and is stated in the insurance code. The notice stressed not to cancel any existing coverage until a new coverage is issued and that the applicant understands what they are purchasing and that this transaction does not duplicate coverage, and if it does, if the current coverage will be terminated. So it's very clear. Other rules requiring replacement: you cannot replace unnecessarily when it results in a decrease in benefits or an increase in premium. An agent, if the replacement is involved, the notice of replacement form has to be completed and signed. And if Medicare supplement policies or certificates replace another, the replacing insurer must waive any time period applicable to pre-existing conditions, waiting periods, elimination periods, and probationary periods if the new Medicare supplement policy is for similar benefits to the extent that such time was spent under the original policy. In other words, you can't have additional waiting periods and elimination periods. So very strict rules regarding replacement. Other laws that affect Medicare in California: all Medicare supplement policies must include the core benefits. The buyer's guide must be given to all applicants at the time of the application, and the outline of coverage must be given to all applicants at the time of the application. And loss ratios for individual policies must be 65%, and For group policies, 75%. In other words, the insurance company has to spend 65% of their premium on claims if it's an individual policy, and for group policies, they have to spend 75% of their premium on claims. So this limits the amount of money the company can take out of the premium for their overhead and profit. Cold lead advertising is a marketing method that fails to disclose that the proper purpose of the marketing call is to sell you insurance and that the contact will be made by an agent or insurance company. You can't do advertising without disclosing that the purpose of your visit is to sell insurance. It's against the law. Agents can lose their licenses if they don't disclose right up front why they are making a call. Let's now talk about the Part C coverage, the Medicare Advantage plans. The Part C program is a voluntary program providing options to enroll in a Medicare managed care program called the Medicare Advantage program. These programs must provide at least the same coverage as Medicare Part A and Part B. Individuals can choose to enroll in the Part C program by signing up for Medicare Advantage Health Plan, also called a Managed Care Organization, MCO, as an alternative to purchasing Part A and Part B benefits through traditional Medicare beneficiaries are not required to enroll in Medicare Advantage health plans. In other words, this is an option. You can buy Medicare Plan A and B direct from an insurance company, or you can buy a managed care plan, the Medicare Advantage plan, which provides all the benefits of a managed care health plan. Managed care is a way of getting Medicare services through a health plan that coordinates many aspects of your care. Instead of finding your own doctors and going to see any doctor who accepts Medicare, persons with Medicare Advantage agree to see only providers within the managed care network and to follow the rules of the managed care network plan. Medicare Advantage plans, sometimes called Part C or MA plans, are offered by private insurance companies that Medicare approves. Medicare pays a fixed amount for your coverage each month to the companies offering Medicare Advantage plans. In other words, you may not have even gone to the doctor. They are paying a monthly fee, Medicare is, to your managed care plan for every member that's enrolled. The provider then takes that money and uses that to pay for their expenses. So you may not go to the doctor for a year, but the Medicare plan is paying your Advantage provider every month for you based on their fee structure. At the beginning of each calendar year, Medicare Advantage plans can make changes to their benefits, premiums, co-pays, and geographic service area. They must notify their members every fall of the changes they intend to make the following year. Now, within the Medicare Advantage plans, they can use two different models, the HMO model or the PPO model. The HMO is the Health Maintenance Organization. In most HMOs, you can only go to doctors, other healthcare providers, or hospitals in the plan's network, except in an urgent or emergency situation. You can go to any hospital emergency room and your HMO will pay for it, even if it's out of network. You may also need to get a referral from your primary care doctor for tests or to see other doctors or specialists. So the HMO, you have to go to their doctors. You can go to any hospital in emergency, and you have to go to your doctor to get a referral to a specialist. A PPO, preferred provider organization, you pay less if you use the doctors, hospitals, or other healthcare providers that belong to the plan's network. You usually pay more if you use doctors, hospitals, and providers outside the network. You can do it, but it costs you more. There is no requirement for a primary doctor and referrals to see a specialist. So there's advantages and disadvantages to each of these plans. Then there's another plan called a private fee-for-service plan. Private fee-for-service plans are similar to original Medicare in that you can generally go to any Medicare-approved doctor, other healthcare provider, or hospital as long as they agree to treat you. However, they are different than original Medicare in that the plan determines how much it will pay doctors, other healthcare providers, and hospitals, and how much you must pay to get that care. Then there are special needs plans. Special needs plans provide focused and specialized health care for specific groups of people. like those who have both Medicare and Medicaid, live in a nursing home, or have certain chronic medical conditions. Care and services is provided by doctors, other healthcare providers, or hospitals in the plan's network, except emergency care, out-of-area urgent care, and out-of-area dialysis for kidney failure. These plans must limit memberships to these groups, so special needs plans are only limited to people in these groups: people who live in certain institutions, including nursing homes, people who require nursing care at home, people who are eligible for both Medicare and Medicaid, meaning you're a low-income individual and have few assets, which means you can qualify for Medicaid, but you're over 65 and you can also qualify for Medicare, and people who have specific chronic or disabling conditions like diabetes, end-stage renal failure, HIV/AIDS, chronic heart failure, or dementia. Then there's a condition called Medi-Medi, Medi-Cal dual eligible. Medi-Cal, the Medicaid program in California, provides health coverage to people with low incomes and low asset levels who meet certain eligibility requirements. While there's several ways to qualify for Medi-Cal, we'll focus on the Medi-Cal beneficiaries who also qualify for Medicare. Individuals who are over a certain age and are disabled. People who qualify for both Medicare and full Medi-Cal are known as dual eligibles or Medi-Medis. The purpose of this, dual eligible special needs plans, are available to those who meet certain criteria such as limited income. These plans help cover all or some of the costs sharing for medical benefits and always include prescription drug coverage. Who is eligible? Including those with a share of cost. If you qualify for supplemental security income, you automatically qualify for full Medi-Cal coverage. In other words, if your income is low enough that you qualify for SSI, you're automatically going to qualify for Medi-Cal. If you're age 65 or disabled and are not eligible for the SSI program, you may be able to get Medi-Cal through the Aged and Disabled Federal Poverty Level Program. One qualification for one of Medi-Cal's programs is limited assets. An individual may have up to $2,000 in assets or $3,000 in assets if you're married. Accountable assets do not include your primary home, one vehicle, household goods and furnishings and personal belongings, a life insurance policy with a face value of $1,500 per person or less, and a prepaid burial plan up to $1,500. So to get Medi-Cal, you can't have any more than $2,000 in assets if you're single or $3,000 in assets if you're married. They don't count your house, they don't count one car, they don't count your furniture, and they don't count small life insurance or small burial policies. But if you got $10,000 in the bank or in a savings account, you can't qualify for Medi-Cal. So you have to be almost flat broke in order to qualify. Now let's know the enrollment in a standalone drug plan automatically terminates if you have a Medicare Advantage plan. So you can buy Plan A, Plan B, Plan C, and Plan D, which is a standalone drug plan. And if you buy the Medicare Advantage plan, it automatically includes drug coverage, so it terminates the standalone prescription drug coverage Part D. The Medicare Advantage coverage, let's talk about that in more detail. Medicare Advantage must cover all the benefits provided under original Medicare. However, Medicare Advantage has some flexibility that Medicare supplements do not have, as well as a difference in the filing of claims. The difference in claims Medicare Advantage versus the original. Medicare Advantage and Medicare Part D plans do not file claims directly with Medicare because Medicare pays these private insurance companies a set amount each month. The insurers then enter into contractual arrangements with doctors, hospitals, and other providers to provide services. In the HMO system, the providers of services are usually paid a fixed flat fee per subscriber known as capitation. In the PPO, the providers are paid a fee for service, usually at a discounted rate. The Medicare Advantage plan vary in the amount of copays and out-of-pocket expenses, but they do have maximum amounts the Medicare beneficiary will pay out-of-pocket per year. If you recall, original Medicare and Medicare supplements do not. So the Advantage plan can put a cap on how much you have to pay out per year. The Medicare Advantage plan may include additional benefits not covered by the original Medicare. Advantage plans must provide the same benefits and services as original Medicare. However, many of the types of plans provide additional health care benefits such as hearing exams, hearing aids, vision care, dental care, wellness programs, exercise programs, and transportation services. Thus, many Advantage plans cover claims to a greater extent than original Medicare. That's the reason you would pay extra to buy this Advantage plan. It may include optional or value-added services and benefits. These additional health care benefits may be included as optional benefits or value-added benefits. Value-added items such as discount, routine vision exams, or out-of-network coverage, or optional supplemental benefits are benefits not covered in Parts A, B, or D, but are offered uniformly to the plan to all enrollees. Let's now talk about the standalone Part D coverage prescription drug plan. Part D prescription drug coverage is an optional coverage offered to everyone with Medicare. Though it's optional, there are penalties for not enrolling in the plan. So they make it so that you have to buy Plan D or you pay penalties. There are 3 ways to avoid a penalty. Creditable coverage is a prescription drug coverage that's actuarially as good or better than Plan D. So creditable prescription drug coverage would include drug coverage if you have it from a current or former employer, or from your union, or from Indian Health Services, or on a veterans plan. So if you already have drug coverage in another plan, you are given credit for having drug coverage. The penalty for failure to maintain creditable coverage depends on the number of months the individual went without creditable prescription drug coverage. The penalty is 1% of the national base beneficiary premium, which is $32.74 in 2020, per uncovered month that the individual was eligible for coverage. This amount is then added to the plan's monthly premium. This penalty may be for as long as the individual has a Medicare drug plan. So while it's optional, Medicare is requiring you to buy a Plan D or you're going to pay a penalty. It covers the drugs. Let's now talk about premiums, deductibles, and co-payments. Most drug plans charge a monthly fee that varies by plan and insurance company. You pay this in addition to the Part B premium. If you are in a Medicare Advantage plan like an HMO or PPO, or a Medicare cost plan that includes Medicare prescription drug coverage, the monthly premium may include amount for the prescription drugs. In 2020, California had 31 standalone prescription drug plans with monthly premiums ranging from $15.70 a month to $145.70, with an average of around $35 a month. Medicare does not establish premium amounts for these drug plans. The insurance company or plan sponsor sets the premiums in advance and through an annual competitive bidding process, and they're evaluated by Medicare. In addition, a Medicare beneficiary may also need to pay a deductible and a co-payment or co-insurance for every prescription drug. Those with higher incomes, starting at $87,000 a year for an individual and $174,000 for a couple, will have to pay a higher Part D monthly premium. I'm in that category. I have to pay a higher amount for my monthly premium for Part D. There is a yearly deductible that must be paid before the drug plan begins to pay its share of covered drugs. Some drug plans do not have a deductible. Those, of course, cost more per month. No Medicare drug plan may have a deductible more than $435 in 2020. Co-payments or co-insurance are the amounts paid at the pharmacy for the covered prescription after the deductible. So co-insurance means a percentage, like 25% of the cost of the drug paid, and it's not a flat amount. So you can have both a deductible and a copay. Maybe the copay is $10 per prescription, but then the copay might say you pay 20% of every dollar after the copay. So if your drug cost is $100, you would pay the $10 copay, and then you might pay 20% after that. Identify how the Medicare enrollment periods work. There are specific times when you can enroll, disenroll, or make changes to your Medicare prescription drug coverage. Let's talk about all three. There's an initial enrollment period. The initial enrollment period is when Medicare beneficiary first becomes eligible for Medicare. This is usually 3 months before age 65 and 3 months after 65. Then there's an annual enrollment period, also known as open enrollment. The open enrollment period provides Medicare beneficiaries with one opportunity to enroll, disenroll, or change the Medicare Advantage plan and prescription drug plan, and it's usually for 2020, for example, it was from October 15th to December 7th, 2019. For new coverage, it started on January 1, 2020. And then there's a disenrollment period. If you have a prescription drug coverage through a Medicare Advantage plan, you can choose to leave this plan and go back to original Medicare Plan D during the Medicare Advantage disenrollment period. If you disenroll from your Medicare Advantage plan at this time, you'll have until February 14th each year to enroll in a standalone Medicare prescription drug plan, Plan D. Then there's a special enrollment period for certain people. You generally must stay enrolled for the calendar year. However, in certain situations, you may be able to join, switch, or drop Medicare drug plans at other times, known as special enrollment election periods. There's about 15 examples in your text of how you qualify for these special enrollment periods under the prescription drug plan. You should review those and commit 3 or 4 of them to memory. Let's now talk about the prescription drug plan, known as PDP, and that you need to know that this may be purchased as a standalone plan or embedded within Medicare Advantage plans. Beneficiaries can remain in traditional Medicare and enroll separately in a private prescription drug plan, or they can enroll in Medicare Advantage plans that may or may not also cover prescription drugs. Most of them do. There are 2 ways to get Medicare prescription drug coverage. The Medicare prescription drug plan, basically Part D. These plans sometimes are called PDPs, and they add drug coverage to the original Medicare. Some Medicare cost plans and some Medicare private fee-for-service plans. The good news is you do not have to know what these plans are for the test. The Medicare Advantage plans, like HMOs and PPOs, or other Medicare health plans that offer Medicare prescription drug coverage, you get all of your Plan A, Plan B, and Part D prescription drug coverage through these Medicare Advantage plans. Advantage plans with prescription drug coverage are sometimes called MAPDs. You need to know that a beneficiary can enroll in a prescription drug plan if they're enrolled in Part A or Part B. To join a Medicare prescription drug plan, you must have Medicare Part A or Part B and live in the service area of a plan that provides prescription drug coverage. To join a Medicare Advantage plan, you must have Part A and Part B. So you can do the separate Part D prescription drug plan if you buy just Medicare Part A, or if you buy just Medicare Part B. But an Advantage plan, you have to buy both Medicare Part A and Part B. It's not really an issue. 99% of people buy both Part A, hospital, and Part B for doctors. Why would you buy Part A for hospital, but not buy Part B for doctors? So it makes sense. Most people buy Part A and Part B, and you have to have both of those to buy prescription drugs through the Medicare Advantage plans. Let's talk about coverage periods, deductibles, and copays. At a minimum, plan sponsors must offer a standard benefit package mandated by law. The standard benefit includes an annual deductible and a gap in coverage known as the donut hole. This gets a lot of press and a lot of negative press early when it came out. Sponsors may also offer plans that differ from, but are actuarially equivalent to, the standard benefit plan. Finally, they may also offer enhanced plans that provide benefits in addition to the standard benefit. Typically, the enhanced plans offer some coverage during the donut hole. The standard benefit is defined in terms of the benefit structure, not the drugs that must be covered under the plan. As stated above, only premiums can vary, but also deductibles and copays. So the initial deductible is going to be increased to $435 in 2020. So the annual deductible is $435 for drugs in 2020. The initial coverage limit will increase to $4,020 in 2020. And the out-of-pocket threshold will increase to $6,350 in 2020. So we'll explain all this. The coverage gap, known as the donut hole, begins once you reach your Medicare Plan D initial coverage limit of $4,020 in 2020, and it ends when you spend a total of $6,350 in 2020. Enrollees paid a maximum of 37% copay in 2019 on generic drugs purchased while in the coverage gap. The minimum cost sharing in the catastrophic coverage portion of the benefit. In other words, after you reach the $6,350, you're now in the catastrophic phase, and the plan pays 95% of all the drug costs. You only pay 5%. So the minimum cost sharing in catastrophic drug in 2020 limits your out-of-pocket to only 5%, and the plan pays 95% after you've spent $6,350 in a year. And the maximum copays show for the out-of-pocket threshold, they're lower for low-income, full subsidy enrollees, and that increased to $8.95 for generic or preferred drugs that are multi-sourced in 2020. So the donut hole is going to close in 2020. They passed additional legislation to close this gap. When it was first implemented in 2006, the Part D drug plan had a big gap in coverage. Drug plans did not pay anything toward the cost of drugs in the donut hole, so beneficiaries were stuck with the tab for the entire cost. Beginning in 2011, the Affordable Care Act took measures to close the donut hole known as the coverage gap. So over the last 5 years or so, beneficiaries have paid less and less for drugs in that coverage gap. Here's how it happened. In 2012, the Affordable Care Act implemented discounts for the coverage gap. In 2019, discounts meant that beneficiaries paid only 25% of the cost for any brand name medications, officially closing the donut hole, and they paid 37% of the cost for generics. Now for 2020, the donut hole for generic drugs is also closed. So the donut hole is closed for all medications. Many think that this means they won't have to pay for medications once they get to this drug payment stage, but that's not the case. Going forward, drug plan members will pay 25% of the cost for any prescribed medications from the time they meet the deductible until reaching the out-of-pocket spending maximum, $6,350 in 2020. That leads to catastrophic coverage. So basically, you pay your deductible, $435. After that, you're only going to pay 25% of the cost until you've spent $6,350. And then after that, any drug cost, you pay only 5%. Let's look at the coverage gap and the catastrophic coverage and how they apply. So most Medicare drug plans have this coverage gap called the donut hole. The coverage gap begins after the Medicare beneficiary and the drug plan together have spent a certain amount for covered drugs. In 2019, Once the Medicare beneficiary enters the coverage gap, they paid 25% of the plan's cost for covered brand name drugs and 37% of the plan's cost for covered generic drugs until they reach the end of the coverage gap. Now everyone will enter the coverage gap because their drug costs won't be high enough. In 2020, everyone will pay 25% for both brand name and generic drugs while in the coverage gap, formerly called the donut hole, until they reach $6,350. These items will count towards getting out of the coverage gap. Your yearly deductible, co-insurance payments that you pay at the doctor's office, the discounts received on covered brand name drugs in the coverage gap, in other words, the money you would have paid except for the discount, that counts towards the annual out-of-pocket, and then what the Medicare beneficiary pays in the coverage gap. So it's not just what you pay, it's what the total cost of the drug was without the discount that counts towards this coverage gap. They have people with MBA degrees figuring out how to make this stuff so complicated most people can't understand it. And that's why there's professional counseling all over the place on the internet and plan providers that can explain this to a typical customer in plain English. In addition to the discount on covered brand name prescription drugs, there'll be increasing coverage for brand name and generic drugs in the coverage gap each year until the gap closes in 2020. We just discussed that. The Medicare beneficiary will continue to pay out of pocket until their total expenditures, deductible, co-pays, and costs during the donut hole meet the out-of-pocket threshold of $6,350. The catastrophic coverage, once the Medicare beneficiary gets out of the coverage gap, they automatically get catastrophic coverage. And with catastrophic coverage, they only pay 5%, small co-insurance amount, of the drug costs for covered drugs for the rest of that year. Here's an example in your text, a nice chart that walks you through step 1, paying the yearly deductible of $435. Step 2, paying your co-payment, which takes you up to $4,020. After you exceed $4,020, then you're in the coverage gap and you're going to pay 25% of the cost until you reach $6,350, and then you're only going to pay 5% of the cost. So study that chart, make sure you understand that flow. Insurance companies must create an annual file, a formulary. A formulary is a list of drugs that Medicare drug plan covers. It includes how much the Medicare beneficiary will pay for each drug. If the plan uses tiers, the formulary lists which drugs are in each tier. Formularies include both generic and brand name drugs. Through a formulary must include at least 2 drugs in each treatment category. It's not required to include all drugs. In a drug tier, various drugs are assigned to different drug tiers and will cost more or less than other drugs depending on their tier placement. When Part D began in 2006, drug tiers were fairly straightforward. That is, generic drugs were the least expensive in Tier 1, preferred brand name drugs were more expensive in Tier 2, non-preferred brand name drugs were still even more expensive in Tier 3, and specialty drugs were Tier 4. For example, cost sharing might appear this way. There's a chart in your book that shows the Tier 1, Tier 2, 3, 4, 5 limits, so you should study that. Since 2006, however, plans have taken advantage of their ability to define their own tiers. Some plans have 4 tiers, while others have 5 or even 6 tiers. The placement of drugs within tiers also varies among plans. For example, the same generic may be a Tier 1 drug on one plan from one insurance company and a Tier 2 drug on another plan from another insurance company and a Tier 3 drug in yet another company's plan. The lack of standardization among the tiered plans means it's virtually impossible to compare plans and Part D cost sharing without the use of CMS's online plan finder tool. While the plan finder is relatively easy to use, Medicare beneficiaries who lack confidence in their computer skills should ask family, friends, their local pharmacy, or state agencies to help them compare plans and plan costs and using the Plan Finder. CMS is the Centers for Medicare and Medicaid Services. It's a state agency free to use, and it does not require that these categories of drugs be covered. So you can't get coverage for anxiety drugs if you're depressed or you have anxiety, no coverage. Weight loss or weight gain drugs, not covered. Fertility drugs, not covered. Cosmetic drugs, like for hair growth, not covered. Cough and cold medicine, that's over the counter, not covered. And then any over-the-counter smoking cessation drugs aren't covered. However, if your doctor prescribes smoking cessation drugs, they are covered. Medicare claims are submitted by healthcare providers and approved medical equipment suppliers to the Centers for Medicare and Medicaid Services, CMS. Claims are submitted in one of two ways, depending on whether or not the healthcare provider accepts Medicare. If the healthcare provider accepts Medicare, the insured pays their 20% and the provider gets paid the rest after they file a Medicare claim. If a provider doesn't accept Medicare, the insured may take the following steps. He calls the provider directly and asks them to file the claim with Medicare. In the event the provider doesn't file the claim, the insured can call the Medicare Center and try to get them to help get it filed. The insured might have to file the claim themselves, and then the Medicare provider will reimburse based on that invoice. So it's always better to go to a doctor or clinic that does accept Medicare, and they're one of the approved doctors. Medicare regulations require that all initial claims for reimbursement under Medicare, except from small providers, have to be electronically submitted as of October 2003, with limited exceptions. Initial claims are those claims submitted to a Medicare fee-for-service carrier. Medicare will not cover claims submitted on paper that do not meet the limited exception criteria. A small provider is defined to mean as a provider of services with fewer than 25 full-time equivalent employees, or a doctor, practitioner, facility, or supplier with fewer than 10 full-time equivalent employees. So a small hospital with less than 25 employees can bill by paper, and a small doctor's office or clinic with less than 10 employees can bill by paper. The fact is, today, most all of them bill by electronic because they get their money faster. Providers that qualify as small automatically qualify for a waiver of the requirement that their claims be submitted to Medicare electronically. And again, today, most of them do it electronically. Medicare assignment means that your doctor, provider, or supplier has signed an agreement with Medicare to accept the Medicare-approved amount as full payment for covered services. Some providers, called participating providers, have agreed to submit all their Medicare claims on an assigned basis. When the provider has accepted a Medicare assignment, it means the Medicare beneficiary out-of-pocket expenses may be less. The provider agrees to charge the Medicare beneficiary only the Medicare deductible and coinsurance amounts, and usually wait for Medicare to pay its share before asking the Medicare beneficiary to pay their share. So your provider sends a bill to Medicare. Once they get reimbursed, they then bill you for your coinsurance amount. So it might be 6 weeks or 2 months later that you have to pay your fair share. The provider submitted the claim directly to Medicare and cannot charge the Medicare beneficiary for a cost for submitting the claim. However, non-participating providers have not signed an agreement to accept assignment for all Medicare covered services, but they can still choose to accept assignment for individual services. If a provider or supplier does not accept assignment, the Medicare beneficiary may have to pay the entire charge at the time of the service. The provider or supplier is supposed to submit a claim to Medicare for any Medicare covered services they provide to the Medicare beneficiary. The provider or supplier may not charge the Medicare beneficiary for the cost of submitting the claim, but sometimes the Medicare beneficiary may have to submit their own claim. The provider or supplier may charge more than the Medicare approved amount, but there's a limit called the limiting charge. The provider may only charge the Medicare beneficiary up to 15% over the amount that participating providers are paid. So we do have clinics that do this. They're not a assigned provider, but they're a participating provider. They'll submit to Medicare, but they charge you 15% more. Medicare Summary Notice, let's talk about that. The Medicare Summary Notice is an easy-to-read statement that clearly lists the insured's health insurance claims information. The MSN limits the details of the services he or she received and the amount that they may be billed. These notices are sent by companies that handle bills for Medicare on a quarterly basis. Let's look at some of the common exclusions again for Part A and Part B. Medicare doesn't cover everything. If you need certain services that Medicare does not cover, you'll have to pay for them yourself unless you have other insurance to cover these costs. Even if Medicare covers a service or item, you generally have to pay the deductibles, the coinsurance, and the co-payments. Here's a list of some of the items not covered by Medicare. Acupuncture, charges that are in excess of the Medicare approved amounts, cosmetic surgery, custodial care except when you get skilled nursing care in a skilled nursing facility or at home as part of hospice care, deductibles, coinsurance, or co-payments when you get healthcare services, dental care and dentures, eye exams routine, eye refractions, which are exams how well you see at specific distances, eyeglasses. None of the eye care wear, unless it's an injury, is covered by Medicare. Foot care routine, like cutting off corns and calluses, not covered. Hearing aids, an exam for the purpose of fitting hearing aids, not covered. Hearing tests that have not been ordered by your doctor. Laboratory tests and screening, not covered. Long-term care, orthopedic shoes, and prescription drugs. Of course, prescription drugs are covered on Plan D or Medicare Advantage, but they're not covered under Part A and Part B. And then travel. If you're outside the United States, Medicare will not pay. You should buy travel, accident, and health insurance when you travel outside the U.S. if you're on Medicare. You have a right to appeal. No matter what type of Medicare coverage you have certain guaranteed rights. One of the rights is to appeal. An appeal is the action you can take if you disagree with a coverage or payment decision made by Medicare or your Medicare plan. You can appeal if Medicare or your plan denies one of the following: a request for healthcare services, supplies, or prescription that you think you should be able to get, a request for payment for healthcare on a prescription drug you already got, and a request to change the amount you must pay for prescription drugs. You can also appeal if Medicare or your plan stops paying for an item or service you think you still need. How do you get counseling? The Health Insurance Counseling Advocacy Program, HICAP, H-I-C-A-P, is a federally mandated and state federally funded program that provides free one-on-one Medicare counseling to Medicare beneficiaries and their families. Trained volunteer counselors can answer their questions and help them understand your Medicare rights and benefits, including how to appeal denials of coverage. Medicare supplement insurance, Medigap policies, Medicare Advantage plans, employee and retired coverages, Medi-Cal, prescription drug, and long-term care insurance can all be explained by the HICAP counselors. The Department of Insurance requires that all insurance companies provide prospective applicants with written notice and phone numbers advertising HICAP services. HICAP also educates the public by providing accurate, up-to-date Medicare information for both Medicare beneficiaries and their families and for professionals, and advocates for providers who serve them. For California beneficiaries and their families, HICAP's website provides Medicare information organized by topic with English and Spanish podcasts available in several sections. For Medicare professionals, HICAP provides current Medicare information and education through the website, an e-newsletter, blog articles, policy briefs, and widely used fact sheets. HICAP counselors are forbidden by law, and they do not sell, recommend, or endorse any insurance product, agent, insurance company, or health plan. They simply disseminate information and educate. You have to talk to an insurance agent to buy a Medicare plan or you can't go through Covered California. You have to buy them separately. Let's talk about consumer advocates. Advocating on behalf of Medicare beneficiaries and their families, HICAP targets federal and state level legislatures and their staff through media and educational campaigns. So HICAP lobbies for Medicare beneficiaries. They also provide free help and legal representation at Medicare appeals or administrative hearings, so you can get free legal assistance through HICAP. And the California Department of Aging administers this volunteer-supported program and operates local area agencies on aging, as well as providing support through training, technical assistance, and up-to-date consumer materials. HICAP provides assistance by phone or in person and provides legal assistance in regard to Medicare and Medi-Cal. HICAP counselors are available for appointments in a wide range of settings, such as area agencies on aging, senior centers, senior nutrition sites, libraries, hospitals, and community centers. Counselors may also visit homebound individuals unable to come to a site. And this chapter concludes with the contact information, email address, and phone number for local HICAP agencies here in California. That now concludes section 15, time to take your test tips.